All right, welcome everyone to Residency Hot Topics. Very excited today to talk about ultrasound imaging and how it can transform your practice. I am excited to be joined by Dr. Bruno Steiner, who is a world-renowned expert in PT-delivered ultrasound imaging. This is being recorded, just so you know. Also want to notify you that the chat and the QA are both functioning. So if you have questions during the talk, please put them in. Happy to interrupt and answer those questions as they come, and we will have time at the end as well. So with no further ado, Dr. Steiner, the floor is yours.
Thank you so much, Ben. So this is incredible praise lavished on me. But I have been teaching this for a while, and I really appreciate it, Ben. And it is a delight to be with all of you. I understand this is going to be transcribed and recorded. This will be relevant to everyone. Obviously, you got in the introduction that you'll be learning a bunch of things, and ultimately, we'll probably achieve our purpose by showing you how I use it within a clinical context. And we will get into billing at the end of it and how to incorporate it into your workflow. You'll get an idea of how we use it and see how that applies to your situation. And just to let you know, it's always an exciting day in ultrasound imaging and physical therapy, especially when you get to use this modality. So this image just right away, I'm going to throw you in. So on outreach, so we take care of the bleeding disorders population of Washington State, and I'll get into more detail about that. But we're relied on to actually ultrasound everybody's musculoskeletal conditions and see what's going on and seeing if there's any sort of nefarious bleeding happening. And sure enough, wherever you go, and every day it's a new adventure. So this person just walked in, essentially wound up pulling their hip while dipping their new bride uh, during the first wedding dance, and he felt a pull in his hip. And I thought, probably nothing, but what the heck? Let me check it out. Sure enough, the guy ripped his gluteus medius. So, there's just every day is just kind of like an amazing sort of session with Muscus to corroborate your physical exam. But anyways, here we are. Once again, thanks for those kind words. Welcome to the Jackson Clinic's Invitational. It kind of sounds like a golf invitation. We're glad you could join us here, and I think this is a really great thing of Ben to make sure the word's out on this amazingly transformational technology that has been incredibly impactful on my career and frankly for patient care. It's just enhanced the quality of our healthcare delivery for our center at the Washington Center for Bleeding Disorders. So ultrasound imaging can transform your practice. And I got to tell you, that's the most succinct way to describe, to say all I really need to say about ultrasound imaging. So glad to be here. Caution, there's going to be a lot of imaging here. And this is just to impress you on the stuff that you can see. It will be overwhelming. You will not have to learn all this stuff. You're not going to be, you're not going to be, I'm not going to call you out and ask you to demonstrate anything for us or analyze or interpret anything. But this is just essentially all these images are just to impress you to see what is possible. My disclosures are I do get research funding and consultation fees and speaking fees from pharma. And I do instruct physicians, physical therapists, PAs, nurse practitioners at University of California, San Diego Health, University of Washington for their Department of Rehabilitation Medicine. And of course, we teach symposia at the Washington Center for Bleeding Disorders and for international matters as well. So this is it's been an exciting ride. I did not expect this when I first embarked into ultrasound. I just knew ultrasound imaging was going to be the transformational thing to practice inherently, but I had no idea how wild it would get, and that continues to get wilder. And you're all witnessing essentially a movement that is really in its infancy, but is not going away. We are definitely making a presence in the use of ultrasound imaging. We always have, frankly. So anyways, just to give you a little background, I am the current president of the Imaging Special Interest Group for APT Orthopedic. This is my second term. I've got 2.5 years of doing this. And essentially, just to let you know, this is our mission statement. Our PT-directed imaging referral and PT-administered ultrasound imaging are cornerstones to autonomous primary care physical therapy practice. I believe this in my heart of hearts. It is what will give us that much more professional relevance and credibility moving forward. Let there be absolutely no doubt this is crucial to modern physical therapy practice. And this is your price of admission, Ben. I'm going to tell you all about a little bit about the Imaging Special Interest Group that we hope you all enjoy. We hope you all join and enjoy, frankly. We do membership meetings and we hold them fairly regularly. We talk about all kinds of things, fresh new evidence supporting our cause for modern physical therapy practice, and particularly ultrasound imaging as well. So there's not a time when I'm not pounding on the desk and clanging the pots and pans and professing how much I love ultrasound imaging. So, it reads like a love sonnet. So I'm absolutely obsessed about it. And sometimes I bring in a few images of, stuff that you didn't expect, and some stuff that's kind of nefarious, like this osteomyelitis of this anterior tibia, that this person essentially went for wound management for quite a bit of time. We found out that with ultrasound, at the behest of our hematologist oncologist, said, "Can you ultrasound this wound?" I said, "Well, we can put some sterile gel on it." And sure enough, we found these erosions with these powerful inflammatory marker of power Doppler into the anterior tibia. And this was really a grave concern, considering this person had a total knee replacement. So we actually suspected osteomyelitis, sent him for plain films to confirm. And sure enough, he did have osteomyelitis. So you're going to help pick up things beforehand. And this is, we're part of the team. If we use this, we can perhaps find things a little sooner and alert all our partners in healthcare. But I just wanted to get this out of the way. Point of care ultrasound imaging. I mean, we're all here from Muscus. We realize that that's the shiny object. And because we're neuromusculoskeletal experts. But I got to tell you, this is not the only thing. There's people in our specialties using cardiopulmonary and cardiovascular applications, like Stephen Ramsey. He's been teaching it as well. We've got people in pelvic floor health and rehab. This is a huge, huge subject. I mean, they're using the heck out of this, and frankly, I still think we're at the infancy of that. And people are even using it in oncology to check out seromas and see what they can do and see how they respond to manual therapies. So it's super exciting. So anyways, as far as professional history, I think I have to give you a little context. I've practiced orthopedic manual physical therapy for 36 years now, and the past 10 years of which has been with the Washington Center for Bleeding Disorders. And only did I join because there was the promise of using Muscus. Wouldn't have joined if I didn't. So, and this, again, price of admission, what's the WASCBD? The Washington Center for Bleeding Disorders. Well, it's our comprehensive care team of physicians, physical therapists, nursing, and social work for Washington State's hemophilia and bleeding disorders community. Don't roll your eyes, because this is supercharged orthopedics. We see everything. So we work alongside hematologists and oncologists who consult with us for our expertise in musculoskeletal and Muscus assessment to guide their medical and our rehab decisions. And by and large, in bleeding disorders care, it's a physical therapist that uses Muscus for hemarthrosis, hematoma, and hemarthropathy detection and joint health monitoring, frankly, for all differential musculoskeletal diagnosis. And like I said, straight up, I never would have joined the center without the enticement of using MUSCUS. And to that point, imaging has proven to be an indispensable staple to determine the causality of our patients' musculoskeletal pain. And we are seeing a continued increase in the adoption of this imaging modality, both nationally and internationally in the realm of hemophilia care. This is my colleague without the mask is Dr. Mark Krimmel. He is also an RMSK. I am an RMSK certified physical therapist, doctor of physical therapy as well. And he and I use it daily as an extension of our physical exam, and it provides our team with that additional crucial layer of diagnostic certainty. And I describe, like I said, hemophilia is really supercharged orthopedics, and our work in bleeding disorders really has exposed us to a full spectrum of musculoskeletal pathology and injury, and it gives us a rare opportunity to image acute and chronic musculoskeletal issues in both pediatric and adult populations. It's super exciting. And at the Washington Center of Bleeding Disorders, it's both physical therapists. Actually, we have a third one there as going charging forward to getting her RMSK, and our medical director has been trained. But really, the physical therapists are performing all of the imaging, and this is consistent with an international survey undertaken by the International Prophylaxis Study Group that identified physical therapists as the super users of MUSCUS in hemophilia care globally. And this shouldn't be a surprise, of course, given that MUSCUS is perfectly suited to physical therapist skill set and rigorous training and graduate training. I mean, you got to realize I actually teach physicians and the whole spectrum. And I'll tell you what, physical therapists just take to this like fish to water. We're really good at this. We're good in our hands. This is something that really is important. So we use it daily at our center for both adults and pediatrics, and we do it for on demand, whether we want to do it or we're asked by our physicians or nurse practitioners or patients, frankly. So we'd like to essentially just if there's additional new pains or we want to get a little deeper into the diagnosis, we just keep the ultrasound on and we take a look at it and see how it's going. So we do it a lot for joint health and musculoskeletal research as well. We like to investigate all kinds of pain causality. And of course, now we've even studied the use of teleultrasound with the remote applications that you use for ultrasound, thinking of actually bringing it into the homes of the patient. Our patients have learned how to self-infuse this very expensive product to treat themselves. So why not get people to use ultrasound at home? You know, it's not that difficult. So I mean, we're all living with, you know, complicated technology with our smartphones and all that. So it shouldn't be a big shock. But anyways, I just want to show you some images and run through to give you an idea. So, you know, in terms of joint health that we look at, this is a view actually of the anterior elbow or the radiocapitellar joint right here. You see the capitellum and this is the radius. It's actually a very pristine looking joint, but here's the stuff. So here's an ankle. You see the thumbnail on the right-hand corner right here. This is the view. And so the value added of looking at this case, and in this case, we're dealing with someone with a hemarthrosis, an ankle sprain or something pinched in the synovium. And we're doing, you can actually perform real-time compression and movement to test the affected anatomy and differentiate fluid from tissue. And that was really quite a revelation to me. And I think we can all agree as movement scientists, this is really kind of compelling stuff to see this type of a hemarthrosis and see the features of the ankle and during that movement. So it's just been an incredible godsend. So this patient's obviously going through some real problems. This is not a simple effusion. This is the type of thing where you have to unweight the joint, otherwise the cartilage gets eaten up by these blood products, and particularly gets worsened if they put weight through it. So the very cautious management of these patients. I'll give you an example. So somebody comes in, and this guy is actually a chiropractor who kind of knows it all. And this guy is a 53-year-old male, and he rolled his right ankle on Saturday while walking his dog. And our nursing staff insisted that he see a physical therapist for a physical and a MUSCUS eval to rule out or rule in hemarthrosis and or other complications. Anyways, he's bruising. I mean, everybody knows there's probably blood in the joint. What do you need? What do you need ultrasound for? So he came in non-weight bearing with his crutches the following Monday. So it was like, okay, I'll come in. Thank goodness our nurse was like very compelling. So he didn't feel like the need to come in, but came in anyway. So this is what a normal ankle looks like. So, uh, so again, the thumbnail on the right-hand side, we're looking at the talar dome right here. This is the osteochondral margin. And on top of that, that black band of anechoic band is actually cartilage. And on top of that, you have the combined interface of the synovium, fat pad, and capsule on top of that. And I think I have it outlined right there. That's it. So this is what we saw immediately. And this is like in a couple of seconds, okay? I think you can agree that that looks startlingly different, right? I mean, it's just blown out right here and leaking into this side right here. And then I should have extended actually the drawing of the circle right into there. So one view is no view, as everybody knows in radiology, or we should all be aware of that. So go into the longitudinal axis view. Here you have the tibia, here you have the talar dome, here you have the talar neck, you have the body of the talus. Look at this nastiness. So obviously we're looking at a hemarthropathy, or rather a hemarthrosis, and doing it in real time just to confirm we're not just looking at a blob of tissue. You're already getting some coagulation right here, but really kind of this is not a simple effusion, this is bloody effusion. But I smelled a rat here. That was the second view. So you go through a couple of views, and I went into the lateral mortis. And here's again, this is the fibula in this case, and this is where you would normally see the fibular ligament, the anterior talofibular ligament. And right here you have the lateral side facet of the talus, and here you have cartilage on top of that. But look at all this hemarthrosis. It's just spread all over the place, but it kept on extending over to the left. So what do we do here? I kept on going. It's like it's still going to the left-hand side. This is looking a little odd. So I tracked over, and then all of a sudden I saw this almost like a crab claw, and just with dorsiflexion, plantar flexion, you see this movement right here, and you see a hematoma come out of it right here. This is just tracking over the fibula. So I think you all know what we found here. And of course, I said, you know what? I'm a little concerned. We're sending you to rate. I wanted to know how bad this was. So I think you all know that this guy had a fracture. So there you go, left-hand side. Now, do we, obviously I told them, you're not going to start trying to put weight through this. We really got to see if something else has gone on. But this gave us confirmation. Why did I show this? It's just to show you how incredibly cool that is. So I didn't have to wait for confirmation. No fuss, no muss. You had it at the bedside. You could just do it super quick. Get him in for plain films just to see if you're not dealing with something even more nefarious. And great, conservative management. No big. Referral to orthopedics? Well, maybe, yeah. And so we did, but what are they doing for him? They said basically walking boot. That was it. So looking at knee joint health, this is a standard view that just giving you examples here. This is the sunrise view. This is the femoral trochlea distally, and this is normal. This is pristine, looking fabulous. This is the quad tendon right here, where it kind of joins up with myofiber. And here's the wedge of the vastus medialis, just to orient you. And then look at that for normal. How about that? How's a patella supposed to move over that? If you saw this, how do you think that would change the way you actually approach exercise with this person? You don't think it would affect it? You're not just going to say, yeah, we'll range of motion them. Well, maybe you would. But now you'll do it with a little sensitivity. Or you're going to go, you know what? We know where this is headed to. But you can have that frank conversation. So this is like every day. So there's so much you can do with joint health. We tend to think of tendons and tendon ruptures and muscle tears. And speaking of which, this is again just a gargantuan tear. This is a hamstring tear. This dancer essentially did the splits in high heels. And this is the ischium right here. This is a posterior view. And the lovely thing about certain ultrasound devices, you can get a panoramic feature very much like you get in using your smartphone, and every notch is a centimeter. Blew out the hamstring here. Look at the size of the hematoma and the interruption of fiber here. It's just impressive to be able to kind of just not just sort of, oh, I think it's this, I think it's that. And your physical exam is going to tell you a lot. But to see the extent of this damage is really just unbelievable. And to be able to see what a contusion looks like and know if there's a contusion, I think you're getting the point. This is the femoral cortex right here. This is vastus intermedius. Here's the bending of the fibers of the of rectus femoris. And here's this really fresh looking contusion. Here's another example. The guy that wrapped both thighs around a mailbox post from a motorcycle accident. You think that's not going to affect the way you treat that patient and how you're going to mobilize them or whatever? And what happens if you don't treat them right with a deep contusion? Yeah, you get myositis ossificans traumatica. And this is what we see. And we're able to pick this up and we're able to detect it earlier, way earlier than X-ray. And of course, you know, you get to see all kinds of rips like this gastric soleus tear. These happen more commonly than one realizes, but look at the peeling away of this, the big hemarthrosis. And this is, again, you're seeing this is in hemophilia patients or bleeding disorders patients, but all normals will get this. It's just that I happen to get to see it earlier because I get them fresh, right? Or if you're not impressed by this, a rectus femoris tear, where it looks like a hole got blown through the rectus femoris, and here the central tendon. I mean, I don't know what to say for you anymore. Uh, isn't that just? It's gorgeous and and the patient recovered. So I'm being glib about the actual amazing idea of what anatomy you can see. And here's another thing. This is the gluteus medius tear that you can measure. And you know, they're blaming all kinds of trochanteric pain on this legendary mythological trochanteric bursitis. It really turns out to be there's a lot of gluteus medius tearing, particularly avulsions and tears at the trochanter. So this is really completely misnomer. We're starting to discredit this with all the studies that are going on and ultrasonographically that we're able to see this. So really important stuff. Once again, you can see hemarthrosis, whether it's in the hip right here. You can see the distension. This is the acetabulum, humeral head, and you see the blood in here, blood product, and the distension of the the iliofemoral ligament. And so it's, and here in terms of differentiating pains, well, this person had a psoas tear, but also has terrible arthropathy and arthritis of the hip joint. So which pain mattered the most? So you get to see what's participating and corroborate it with your evaluation. So really fabulous how you can see all this stuff. And even this picture, which is surprising just based on just how it's kind of like separating. So this is a serosanguinous separation, it's serous fluid and then sanguinous fluid. So really kind of absolutely cool. So I got to get you in the brief history so you realize we are not Johnny come latelys on the scene here. So physical therapists, of course, we've been using therapeutic ultrasound for what, 60 years. And we have a long, long history of pioneering ultrasound imaging research since the 1980s. So we've been here. We've been developing the sciences. So if anybody tells you that, oh, this is a fad and it's experimental and it's not validated, it's a whole lot of horse feathers. We have been around. We've been doing a lot of research in this realm. And you have to correct anybody who's willing to tell you that, oh, it's another fad. You guys just want more. You want more privileges. There's no precedent. There's huge precedent. Don't let anybody get away with it. So, and briefly, you know, there's been a slow adoption because it takes practice. God forbid you have to practice. Trust me, your degrees, your DBTs, a lot more difficult than this. But there is a really big uptick, and physical therapists are part of this uptick in use. We're ahead, believe it or not, in RMSKs, ahead of chiropractors. We're ahead of of orthopedists. We're ahead of nurse practitioners, allied health, but the physiatrists and pain management or physical medicine, they have found a new lease on life with this modality because they're practicing all kinds of ultrasound guided interventions and they're effective. But we got to stay in that room and keep working at getting ourselves that RMSK. But we're doing a good job. Remember, there's an impressive record of safety. There's no radiation. I mean, you'll probably harm the patient more by screaming at the tissue at the top of your lungs. And that's not going to happen. It is validated for the identification of all kinds of musculoskeletal pathologies. Rest assured, this is just vetted. Generally, it's applicable to most joints and associated neuromusculoskeletal structures in lower, upper axial spine, and pediatrics and adults. It's great in pediatrics. It's so interesting with their arthrology because you're dealing with all these endochondral ossification centers, and it's super exciting. And remember, joint arthropathies, you can see it all. It's super important in really determining the joint health of your basic arthritides and seeing whether they have simple effusions going on, getting evidence that something went on. So here's an example. Yeah, it's great for diagnostics, but you want to know the severity and the extent of tissue damage. You can do a physical exam, get a really good ballpark idea of what's going on with the patient. But when you get this extra data point, just to let you know how extensive the damage is, whether you're dealing with joint arthropathy, like we saw in that sunrise view of the distal femoral trochlea, where you had these cortical breaks in that smile image, really lets you know where that person is and what their likely trajectory is, or it'll help you fashion how you're going to treat this person or what recommendations you're going to make to actually getting them to a physician or whatever. Once again, it's not all about tendon and ligament. It's about muscle. It's about joint arthropathy. It's about bone. You can see small stress fractures that are not picked up by plain films. Don't be surprised if you see little avulsions of tendons and ligaments. You can see Osgood Schlatter's just like that. It's remarkable. Nerve entrapments. You can see ulnar nerve subluxations very easily, and you can see pathology. I mean, really nefarious stuff. And the better you get, just the better you're detecting it. So, what are the advantages and implications? Well, needless to say, I think you get the point. Improved diagnostic accuracy, and always in the context of an extension of the physical exam. You always do that, whether it's just seeing the patient walk in, doing some basic palpation, doing whatever. But this is a huge, huge part of modernizing our practice and professional relevance. It has done wonders in our center, and it's just wowed the professionals. And frankly, they rely so heavily on us for this. They absolutely want the ultrasound and our physical assessment immediately before they even start. Opportunities, really professional advancement, integration in comprehensive multidisciplinary care models. I think what we're doing in hemophilia as becoming the de facto musculoskeletal experts, we could import that model to any sort of model, working with, frankly, internists, generalists, you name it. I think this is really exciting, and not as an employee, but as an associate. And the thing that I didn't anticipate was the educational benefit for the patient. I'm blown away how much we got more buy-in from the patient, and they're seeing their image. It just, the diagnosis means so much more when they can see a picture of it, and they really are fascinated by it. So I think it is primary care physical therapy practice. Here's the units that we use. We just bought another one, as a matter of fact. We use really high-end stuff because we do a bunch of research as well, and I'm obsessed about diagnostic accuracy. But I got to tell you, the handhelds are getting way better. This is Clarius. I'm not here to sell you Clarius, but I just think these guys have really just made some amazing handhelds with some amazing definition. So really good. But they're getting better and better, and you can use them with your tablet or your phone. And there's remote capabilities as well if you want to consult with somebody and help you navigate an image. So really, it's pretty amazing and really great definition. So it's all too good to be true. Are we really allowed to use it? And well, the institutional support is there for PT-administered ultrasound imaging. So I'm going to point out what I think is a linchpin argument for for PT use of ultrasound. We created documents for it that give you a history and a review of how much research has been performed by physical therapists, all the jurisdictions where we can practice it in. And also just remember, your national organization, whether you endorse it or you don't, they're still super important from a legal perspective. The House of Delegates, has essentially said the physical therapist may also perform or interpret selected imaging or other studies. That was basically a way of saying you can use sonography, but I drilled down on it because I asked them point blank. I said, do you recognize ultrasound imaging as part of our practice? And knowing full well I would get the response because I knew who I was dealing with, because I knew what that language meant. But I wanted them to say it. And yes, our national organization recognized it. That's a big deal. In the legal precedent, in the absence of it being in your Practice Act, the legal precedent tends to looking at the language of your national organization if you went to battle with it. So this is an important statement. It is not nothing. So the APT is very relevant. So I want to give you an idea because I got a feeling the way Ben has done some serious outreach on this, and he's made it his mission, and we're so glad that he recognizes the importance of this. You got to know what's going on in your state. So we love to run a nationwide diagnostic ultrasound scorecard. It is always in flux, and let you know the state of it. So you're getting a presidential briefing here tonight. So here you go. First off, no prohibitions in the military branches. It's actively taught. It's used. Don't believe me? Ask John Umlauf, who's been teaching it for God knows how long. He's not in the military anymore. He's now moved to academia. I always give the PT directed imaging privileges scorecard. This is not ultrasound. We can go over this some other time. We're making serious inroads. Everything in grade is silent practice acts. They're not telling you can't order imaging. Deep green, we're ordering everything. Pale green, radiography. Red, not good. Bad language. But North Dakota just actually had a substantial victory. We have to give kudos for full imaging privileges. They came from being a pale green and they nailed it. And persistence pays off and preparation. Oregon, really cool, was the first state to actually have it written into their legislation for physical therapists to use ultrasound devices. That's a big victory. But in other states, whether Nevada, New Mexico, Hawaii, Texas, let me see where else. I had another thing. Virginia. So where the transducer heads are, the white transducer heads are essentially from the declaration of their state boards. They said physical therapists are authorized to use ultrasound imaging for evaluative purposes. That's really huge. North Dakota had some really bad language, and we are working to reverse that. Some really exciting stuff is happening. We should be getting news of it imminently, maybe in the next month. But I'm super excited that will set an enormous precedent. This is the real scorecard that you have to pay attention to. Is there prohibition? Nah. There's no prohibition to a physical therapist using ultrasound imaging. With a technicality, again, North Carolina is still kind of, we've got to deal with the situation there, but we are feeling really, really Good. We'll see where that goes. Kind of know the answer already, but let's wait on that. Virginia, your home state, Ben. You guys are allowed using it. There's just a little technical language glitch there, but it's imminently nothing's holding you back. Most annoying is the no interpretation allowed in Alabama. In a devil's bargain, they were so desperate to get direct access that they essentially allowed all kinds of really bad language installed on their Practice Act. And part of it was that they're not allowed ordering tests, they're not allowed ordering imaging, and they're not allowed interpreting imaging. So it doesn't say you're not allowed using ultrasound per se, but imagine if I had that big hamstring tear or that contusion or that big hole in the rectus femoris that I showed you. And I'm doing it on the patient. The patient goes like, "Oh, so what's that?" And I go, "I can't tell you." And you know darn well what it is. I mean, it's so Neanderthal. This type of language. This shouldn't be allowed. But I think, look, I'm not in Alabama. I think they really wanted direct access, but I think they could have walked away from the deal. They're going to have to fight to another day to get some bad language removed from their Practice Act to modernize the Practice Act. This does no service to their public health or their patients, but nothing stops them from using it to corroborate their evaluation. And I still think there's probably some language you can use that could skirt the issue. But anyways, everything in green, you're free to go. There's no prohibition. There's some language that's more favorable, more indicative, but really the skies are clear. So there are sonography boards that are emerging. Interestingly, only the ones in pale blue and the one in green. You got to watch out for these guys because the boards can sometimes they don't really know what we do as a profession, as many of our colleagues don't understand our profession yet, even though we're doctorally trained. That might be on us too, that we need to communicate with other professions to let them know that we are the neuromusculoskeletal experts and that we're crucial to the functioning of society and even military readiness, frankly. Just read the report from the military branches. But anyways, what's interesting about the one in green in New Mexico is they actually recognize this sonography board recognizes the RMSK, which I'll explain is the emperor of all MUSCUS certifications. It is the physician credential of MUSCUS, and they recognize it. That's why I say if you have trouble with any language on your boards, if you get the RMSK, that is your linchpin. It supersedes everything from in my impression from a legal standpoint. The one thing I like to say, sorry, Ben, this is part of my messaging for the imaging special interest group. If you are interested, you are insecure about your Practice Act, and you're about to make a really bad question to your board that will facilitate a crappy answer, I could use more sailor-like language if you want to get me going. But please, if you are insecure, consult us first. We'll let you know what's going on. If you want to craft a question for your board, whether it's imaging referral privileges or diagnostic ultrasound imaging, please consult us. We've already created the language. It is available to you. I will help you. I'm very rapid response. I answer my calls. I think I do, Ben. uh, Anyways, please don't reinvent the wheel. Please contact us as you trailblaze forward in your respective states. Okay, so as far as this, you got to know. As far as institutional support, the American Institute of Ultrasound of Medicine recognizes physical therapists as licensed medical providers of MUSCUS. This has been a huge relationship for us. They recognize us. We provide content for their webinar. They have the vaunted Journal of Ultrasound in Medicine, super important support and precedent from us. And speaking of really important synergies, the gold standard credentialing body Intellios with their global mission, and this is the gold standard for the USA, and their registries recognize physical therapist eligibility for their certifications. And notably, we should all be taking advantage of this particular one from the Alliance of Physician Certification and Advancement. This is for the RMSK Physician Credential of Muscus Imaging governed by Intellius. So this is huge. We get to sit this exam. We pass this exam. It happens twice a year. We do this well. It is a hard exam, but knowing physical therapists, we're so obsessive about making sure we get it right. We do this well. And so, but there's another route, and I'd be remiss if I didn't tell you about it. This is their POCUS Academy, the Point of Care Ultrasound Certification Academy, and they do a great job with a fantastic offering of certifications, even in Muscus. It still requires some case preparation and casework. It gets vetted, but it is a very nice certification to get if to build toward the RMSK. I went for the RMSK first, but this is a nice way of getting into all these different sort of domains. Doesn't have to be Muscus. They've got all kinds of learning opportunities and certifications, so you need to investigate. And speaking of learning, I just had to show you, people are learning it at school now. I'm teaching it at the University of Washington for their DPT program, and it has been these students absolutely engrossed in this, and they are loving it. Do not be surprised if they come to the clinic if they want to get hired by saying, is like, are you going to let me practice ultrasound? They might buy their own unit. I've been telling them to, and I'm not stopping. And they're getting the price point's getting easier. And also with the POCUS Academy, we've been creating a PT working group and a PT academics working group to allow students to actually gain access to earlier certification. So these are exciting times. So if you're a student, bravo, get on it. If you're already practicing, watch out. People coming behind you now are going to want this skill, and they're going to get good at it. So, but we're all very much in the beginning of this. So let's talk tendinopathy detection in Muscus, because you want to know how my daily flow goes. And I just giving you some, I'm just trying to convince you that this is really amazing. So anyways, let's say you have a patient come in and they've got a tennis elbow. It all tracks, right? Either you're doing the resisted wrist extension. It hurts like the blazes. And this is an image right here. This is a normal person, no symptoms. This is kind of a longitudinal axis view. This is essentially right here, I think got the labels here for you. Yeah, this is the lateral epicondyle right here. This is the radial head, and right above it is the common extensor tendon. So kind of has that mother of pearl sheen to it of repetitive fibers. And then you have the myofibrils, more hypoechoic on top of that muscle right here. So this is normal. So patient came in and basically said, yeah, I've been dealing with this pain for a couple of years now and blah, 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 and it doesn't get better. I don't think it's a bleed, but, I still had to do all my measures. So I decided, okay, let me check that. And it tracked. It's totally tennis elbow. It's lateral epicondylitis. I'm getting that. That's no problem. But the thing just wasn't getting better. It's been taking a year, and no one's giving him any reasonable advice. They're suggesting strengthening and all this stuff. The typical, boilerplate. Let's have a look at it and see what's under the hood. That's what we see. I'm going to go back again. That's what we see. This is normal right here. What do you see? Do you see that nice fibrous echo texture? No, the guy blew it out right at the origin. You can even see a dent here. It's like a mouse took a bite out of it. So this is not good. That is a tear. So what are you going to do? Now that you have that information, do you think you're going to wind up going like, you know what, we're going to do a lot of reps? No, this changes the game. What do you do? Didn't want to have any dry needling. He didn't want to have any sort of PRP. So we did some manual therapy. I showed him how to do some stuff, and the thing finally got better. I actually couldn't believe it because when we tracked it, it was actually looking better. The hole was smaller. And it was like, okay, that's an N of 1. Either way, I think it'd been a great candidate at some point for dry needling. But the guy's doing fine right now. But we really had to really radically modify his activity, um, reapply a brace, and just do some and make sure he wasn't, doing ballistic loading and getting away from stuff that's just aggravating on top of that. So just seems common sense, but when you have this extra data point, it really affects things. So now here's an example of a guy who's a martial artist, black belt, jiu-jitsu. And he also presented with lateral epicondylitis type of stuff. If you did the exam, I promise you, the range of motion was good. It was sound, but he had really problems with. He's still strong in his wrist extensors, but it caused pain, reproduced the pain. So I'm going like, let's check this out. Sure enough, avulsive fragments and a fragment here. Look at the radial head. There's a little chunk out of there. And on top of that, you're getting this right here. So you're you're getting ligament that's also been avulsed as well. I mean, been ripped. So how does that change your picture? This is not just simple tennis elbow here. So what are your instructions? It's not going to be strengthening. I hope it's not going to be strengthening. So, but this guy likes working through pain, but that's not a good strategy. It hasn't been serving him for the last 3 months. So, luckily, this picture and this guy was a know-it-all and is super intelligent fellow with super, very rigid character. And but when you show this incontrovertible evidence, you've got your ace in the sleeve to get buy-in from a patient and help them along. You know, so just to give you an example, and patellar tendon tears, if you don't think they happen at the inferior pole, you'd be wrong. Look at that chasm right there. This, when you see mother of pearl finish and you'd see this hollow kind of a, uh, kind of like graying out, that represents edema. And this guy was hurting for certain. This even had power Doppler signal, but that's a patellar tendon. Are you going to allow this person to do deadlifts like he wants to because he wants to work through the pain? No, you're going to be working this a different strategy to make sure that this person is doing okay. Here's a tear, very evident one in a bad Achilles tendinosis. And here, I wish I'd have showed you a normal Achilles, but this is a panoramic view once again. So usually you're going to get about 0.40 thickness, centimeter thickness out of this. So, but in this case, tendinopathy, tendinosis, massive kind of hypertrophy, and all this is changing in composition. It's no longer got that fibrous echo texture, and there's actually something that's going on that's histologically definable with it. And I'll show you an image of that. But this means something, and this person is in danger of rupturing. But imagine if you've got this, you've got an athlete, and you go like, you know what? You've got to cool your jets. I'm really worried about this. This needs treatment. You better take care of it now. Otherwise, operation, then you're really out of it. But check this out. I just went on outreach, Ben, to just northwest Washington State, the guy that basically had a raging Achilles problem. And he had that side effect from fluoroquinolone antibiotics. This is the only one I've seen in my life. It might be the only one you guys see, but check this out. Right? Again, just going to navigate. I'm not going to tell you what this stuff is yet. So this is the heel. This is the spur, right? This is a spur, big, nasty spur coming off the calcaneum. This is the tendon footprint. Here are the fibers. They look kind of modelly. Look at this massive extension of hypertrophy. This is almost 5 times what it should be. It's very characteristic. And you see this in a second, by the way. This is not even a hard view to get. It really is not. But what the heck is going on here? This is heterotopic ossification. This is ossifying in here. These are nasty. Just really a terrible development. And you can see the shadowing here. Why is we call this acoustic shadowing? Why is it happening? Because we know this to be solid and calcific. That's what, if these were just kind of general blobs in the area and it didn't cast a shadow, well, you know at least it's of a different composition. But this is really impressive stuff. How is that going to affect the way you treat this patient? How is that going to affect how you refer the patient? I know what this stuff is. I know how to go about it. I've done studies on it. Like I said, when you do muscus, you're a target-rich situation for research. Look at this area right here where you're getting this. I'm looking at this for the second time, just because I just literally uploaded this like an hour ago. Uh, this is imminent for actually ripping. So he didn't come in with crutches. So I totally said, I got to immediately put you on crutches. We got to watch this. You do not force yourself and walk through the pain here. So instruction, instruction, instruction. And I still think we can get rid of this and down the road, hopefully let this calm down, shrink. And if this is still there, consider other things. This is not operative, but there might be some ultrasound guided procedures like barbotage. Anyways, little TMI. Let's go. So when it comes to this, that histology, when we're talking about the graying out. So when you get that nice shiny mother of pearl look, you get this is what you're seeing histologically, really tight bands of collagen and the collagen cells. This is what you're looking at when you're looking at the hypoechoic. They've matched this histologically. It's really like a mucoid. It totally loses its integrity. It's mucoid, it's kind of slimy, and it's begging to rupture. As a matter of fact, I had a friend that actually ruptured both both quad tendons at the superior pole. I thought this is impossible. I ultrasounded myself, like, holy Moses, this is like after the operation was done. And my friend asked the right question, say, hey, what did it look like when you operated on it, to the surgeon? And he said it's just kind of slimy. And so not just like a fine rupture or something like that. And this guy said, oh, he was like, he's a climber. He climbs Mount Rainier. He came back from Denali uh, ascent, and he was actually descending so eccentric quads all the way down Rainier. And then he basically happened at night. He was stranded with his dog, and he had to be rescued. But anyways, so he complained for about a year and a half of knee pain. And I said, well, you want me to have a look at it? He said, no, 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 it's my gout acting up. It never was gout. He was working on this type of problem. So I'm here to tell you, you can make a difference, know what's going on, prevent this horror. He's doing well, but still, this is a problem. Now, here's a really interesting finding. Again, this is just to overwhelm you. Here's an anterior hip view, one that not really in the textbooks. We kind of like just did it ourselves. This is what physical therapists do. We tend to get creative looking with views. Here you have again, you have a view of the femoral head. Here's the acetabulum right here. Here's the labrum a bit. But we're looking at a pain of a hockey player. And sure enough, we found these findings in the actual rectus femoris attachment on the AIIS. Who'd have thunk it? This is not arthritic pain. This has everything to do with what's adjacent to it. And in an even better view, check this out. And this is chronically bothering this individual. Well, we have an explanation. Now, how many people would want to blame that on an arthritic process? So super important on how you treat it. And speaking of avulsions and tendinopathy, this is a sartorius avulsion. At the ASIS, you see fragments right here. This is the hematoma going with it. Do they happen? Yes, they do happen. And this is not just in a hemophilia population. And the cool thing, didn't allude to this, but this is this power Doppler signature, where basically it measures slow flow blood flow. This is great for finding really nefarious pathology. And this basically shows an inflamed area surrounding the hematoma, indicative it's going through a repair phase. But this is really kind of gives you that smoking gun of something's active, and this is what's really the concern. And avulsions, again, this is an inferior infrapatellar view, longitudinal axis. Here's the inferior pole of the patella. Here's the patellar tendon. And what do we have here? Here, fibrous echo texture, and then all of a sudden it's interrupted. And then you get these things, these rocks coming off the tibial tuberosity. Osgood Schlatter, palpate it, look at it, and go like, it's 2 seconds, you know what's going on. And you can track how it heals as well. So really spectacular stuff. Now, one more thing that I really want to get to is, so this is, what about shoulders? Okay, fine. This is a short axis view, very typical view. Let's see, this is coracoid process. This is looking at the subscapularis peering out and attaching to the lesser tuberosity. Here's the bicipital groove. You have the long head of the biceps right there, transverse humeral ligament. Here you have deltoid, subq fat right in here. This is the epimysium of the deltoid. And here's the greater tuberosity. Get a view of that, hold that in your head. Check out the next image. How is that different? This patient fell in the bathroom. Young buck, strong, but held on to a bar and just yanked and just came in. It's a lot of pain. And because we have to watch out. It's like, and did he just have a bleed or something like that? Of course, he did have a bleed, but what the heck's going on here? It's not even recognizable. You see this distension of the transverse humeral ligament. Look at this. It's like the long head of the biceps naked. You've got this freaking break right here. You go, what the heck's this? And you go like, you know that I referred this guy for MR. And plain films. Plain films didn't pick it up. Needed MR. So I took another view with a little external rotation. Again, coracoid. Here's the subscapularis. It's attached, but you got this break right here, break right there. So what the heck's going on? Had an idea it was not good. This is the corroborating image. It looks like a landslide happened off the lesser tuberosity. So fracture. All this right here, this is not T2 weighted imaging, this is T1 weighted imaging, fat saturated, but this is hemarthrosis right here, hemarthrosis right there, but really fabulous. I mean, again, so think about it. This is a normal view of a longitudinal axis of the hip. Very nice looking. There you go, iliofemoral ligament. You telling me that's not going to impact your decision making when you're working on a patient? Again, look at this area right here. That's the iliofemoral ligament, the labrum's right here. Let's go to the next image. Look what happened. That's bad news. I mean, it's not, and he's got some thinning of the cartilage on top of that. Things are going on, but this is a constant problem. And he had a gluteus medius tear. And this is a young guy, just a runner. And so this is a labral tear and just a pretty impressive view on it. Or you can have a kid that basically just wasn't getting better on his greater trochanter. Again, too early to get a trochanteric bursitis, if ever. What do we see? Well, in physical therapy, we sweat the small stuff, and this is what we picked up. The guy cracked the trochanter just a bit. Stress fracture or a little itsy bitsy thing, but it was causing him problems. But with the right guidance, totally was able to do this nice and easy. Here's gluteus medius attachment, but it happened like literally within the attachment. So, but this is the type of stuff you get to see, and that no one's going to take the time to look at. It doesn't take that long. And here's the other thing that I want to impress. We're almost done, guys. We're going to talk more advocacy. I'm going to try to breeze through this. This is total knee replacement. This person is getting this. We're able to actually see hemarthrosis and detect the nature of any sort of swelling that's happening within a total knee. You don't really, you can't do it in an MRI based on all the artifact. You're just not going to get the detail. And MRI does not distinguish simple effusion from a bloody effusion. It just can't. It's not the nature of it. Here's another view of the lateral recess of the patellofemoral joint, and you can pick up all this horrible inflammation that's going on for this patient. Okay, and just to show you, this medial gastrux tear that happened from a person doing a layup in basketball landed incorrectly, big, massive hemarthrosis, and not hemarthrosis, hematoma from a split of the soleus from the gastrux from the soleus. This is the medial gastrux. But the nice thing is, because it's such a difficult patient, very medically challenged, even though he's a young man, I was able to basically modify his activity, really figure out a game plan to getting better, and you could track it. So, and you could track the times when it was actually a little more fluid filled. Turns out there's a different dynamic going on when people repair. That's all right, but I was able to track it and see fibrin formation, seeing how it evolves, and seeing if it actually is retracting, repairing. How useful is that when you're trying to return somebody to sport? I mean, if the patient is feeling no pain here, you want to return them back to sport here? Now, can you hear? You should basically ring bells in your mind where when an orthopedist or somebody says, "Well, do as tolerated." You're going to do this as tolerated. It's nice to then be able to at least, when you got this image, you basically said, "No, we're not waffling on this." Here, I'm still going like, "At your peril." Here, still repairing, but it's like, anyways, you basically have more data points. This is a contusion, very bad fall off 4 feet high into a pool. The guy didn't know that there wasn't any water in it. So this is just a really bad injury, bad contusion. It resulted in this remarkable myositis ossificans traumatica. And then just look at the shape of it. So it's really amazing. So we wanted to have radiography done at the same day, just to know. It was early on in the game. I really didn't think we really needed to, but I wanted to get corroboration. So I told the radiologist specific instructions. I mean, I unequivocal about it, and saying, "Hey, can you check this out for heterotopic ossification?" Literally drew a circle around the area, and got this result back. And I'm wondering if you can see where it is. Hey, you can see, where it's at, right? Is it more proximal or distal? Just to check you out, Ben. It's more proximal, right? Yeah, exactly. It's that, right? It's not his keys. This is the report. So this is not a gotcha moment. This just shows that my teaching point is that look at the images. Don't just rely on it. You guys are graduate trained. Look at the images. Get a feel for it. You're on the same team. If the person missed it, you can have that conversation. We're not here to go, "Y'all suck." But we are here to say that we belong here and we are an extra pair of eyes for you. And that's why we do this, because this is about the patient. This should not be about ego. I think you get my point. But if you look at one image to the other, what's more impressive to you in terms of the detail? And look at that. Look at the contours of this. Look how it's embedded in the vastus intermedius. Look at the acoustic shadowing. How can you not be impressed by that? Anyways, recommendations for those to jump in. There's a bunch of you that maybe really want to know how to do this. I know I'm taking a lot of time. I am so sorry, but this will be worth it to you. Look, this is what I think. Buy yourself a handheld or a laptop. Consider the remote capabilities of it. I know, it seems like the place of your employment should buy it and they should invest in it, but you're not going to have that luxury because they might actually not have the vision that Ben has for their clinical context. I think they're way ahead of the curve on this in philosophy. I think they really have a passion for where they want to go with this. But if you don't, nothing stops you from getting it yourself. The Clarices run, they're not that expensive. Getting a card note is way more expensive. So think about what you want to do there. You can take courses supported by with a library of videos. There's a lot more resources available to you. When 10 years ago, there was nothing for me. I was just like scrounging for anything. I wound up finding a course, by happenstance through University of California, San Diego, and their hemophilia thing, because they were adopting it for this really complex pathology. And so luckily, but literally I had to form my own curriculum. But now physical therapists are getting great at teaching this stuff. There's all kinds of stuff. So I say just like make sure, pause the video and look at the POCUS education provider PEP program. This is Intellios once again, and they got a whole bunch of providers that have been vetted, and there's a lot of cool courses, a lot of great providers. Just check out the prices, but make sure you get a library of videos to help you along too. Hands-on course to be there at a course where you're using the hands, getting on a machine right away. I absolutely tell you, this is my advice to you. Make sure you're doing majority of the time hands-on with that probe. Didactic is fine, but really make that limited. Do your course prep. You want to practice, practice, practice. Don't just, it kind of reminds me, it's, don't read about the tango. You have to do the tango. And don't know why I picked that analogy out. Frankly, I'm not even like, but you gotta get the sort of hands-on skill to do it. Take a prep course. If you're looking to get better and you want to do the RMSK, prep course is really good. It gives you the lay of the land of what you got to know, the practice questions, and give yourself a year to study. This is not designed to basically cram. You've got to really study for this one. And you have to do 150 cases in preparation for the RMSK. You don't have to do that for the CERT MUSCAs. There's like 6 case studies that you have to present ultimately for that certification. Totally doable. But for the RMSK, you got to log 150 cases, and there are plenty of platforms out there so you can bring your cases to have them vetted and people sign off on them. So as far as fellowships versus creating your own, I had to create my own. And frankly, most people created their own. Now they're offering fellowships, but I would ask you consider the cost. Either is totally doable, but I curated my own. And my advice to people is, well, I'm not proficient enough, and da 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 da. Look, then take another course. And if you're still not feeling good, take another course. Talk with people, practice. The only way to get better at this is keep practicing. But there's all kinds of images, all kinds of websites to help you now look at and compare. So you're not alone. 10 years we were alone, and I still got it done just by, I know how to study. We all know how to study. I don't need to tell you this. You're all DPTs or you're becoming DPTs. You know how to study now. You don't need that much hand-holding, frankly. So curate your own program, but whatever. Here's a couple of books I think that are absolutely important. The John Jacobson book is really kind of the Bible in terms of the RMSK exam, because you have to learn procedures as well, or have to know about them. And like I said, it's a bit of a capricious exam, but we'll pass it. And get an ultrasound, sonographic principles and instrumentation. I like this book. They've got a lot of questions in it. Know it cold, because there will be a physics part of the exam. You got to know it. You got to just do it. There's some principles in physics that I thought was like particularly difficult in Snell's law, but what was really great? Khan Academy was great at explaining a lot of physics. And frankly, ChatGPT 5 is like pretty darn scary good. So use everything to your advantage. That's what I'm saying. Investment. Hey, these handhelds cost like the Clarius, the L15 that I think is really kick butt is $3,750. Coursework costs vary, but range from the obscene to the totally doable. So I like, just watch out. You can leverage there's no reason for you not to start. You don't have to wait for a fellowship. Just get involved. If you need it after, hey, great, that's cool. Like I said, look at the Intellios list of PEPs. And in terms of getting paid, everybody's question for sure. Return on investment. If I'm doing this much investment, what is my return? The more I'm having these conversations, I'm having them weekly. People are, it's totally happenstance. There's 1,500 insurance policies. Everyone's exotic. You're fighting one insurance company, and then you might get paid by one, and then all of a sudden they decide they don't want to pay it, or then they wind up putting you on a fee schedule that's kind of ridiculous. Um, ult- uh, Medicare is showing signs of paying for the codes, and then all of a sudden, because they're paying like $20 for an evaluation of ultrasound. I'm sorry, that's not doable. Cash is king. Your patients will pay for it. They will pay for expert work. So get good, but you will get paid much more handsomely for the work that you're doing and the effort that you're doing, and it'll still wind up being cheaper imaging for your patient in the long run and much better care. So I'm sorry, I wish we could have a better story for you on getting paid on codes, but the future doesn't look good that way. It's going to require something different. And fighting every one of these uh, these insurance companies, it's a fool's quest. Um, you know, I'm okay with fighting windmills. It often feels like I am, but I'm making progress. But I know this tackling 1,500 one at a time. The only one that's really worth tackling is CMS, but they're already showing sign. We've got something in the works where we're trying to get reimbursed, the RMSK to be reimbursed, but I fear the code will be reimbursed at ridiculously little. So what use is that? It's really not cool. Um, so I think it's going to take another approach, and we have to basically that is a legitimate legislative approach that has to happen that deals with this. Our profession is under siege when it comes to. I always said it in my private practice. I was, in private practice for 27 years. I had a robust following of patients. And but I always said, man, they're just finding new ways of cutting us. And I said, this is the death of a thousand cuts, and it's still happening. And to stop the bloodletting in a profession that is so critical to the health of this country, we have to do something pan-nationally and bring insurance companies to their knees on this. Sorry, it sounds radical, but this is the only way forward. It can't be. It's noble to fight each insurance plan and declare victory. That's wonderful. But frankly, it's like the 1,500 headed Hydra. You cut one, you're going to figure out another way to not pay you. Sorry, that's just the way. And I've talked with insurance reimburse payers and executives that I actually fix in clinic, and I said, is it my imagination, or they basically pick on us for short term showing that they're cutting expenses in their quarterly report, and we're the easiest target because we have no recourse. And I get these smiles saying, "Yeah, that's exactly it. People don't care, and you're a target." It's like, yeah, we need a different approach. Sorry, I digress. There are codes; they're getting paid. I say go for the complete code because you're going to spend a lot more time than most people on the code. Ethical concerns. We can bill and see if we can get reimbursed, but don't start making diagnoses when you don't know, and you're you can always make sure at the beginning you are relying on your physical exam. Look for corroboration. Build in like 10 minutes where you can actually take a look at what I call the bobo spot. It's like the pain's right there. Uh, I'm just going to go longitudinal axis, short axis, and see what I see. Maybe I'll see an effusion. Maybe I'll see something. Maybe I'll see a bony irregularity. I'm going to do some motion on it. See if it corroborates, but don't get hung up on creating a diagnosis or a diagnostic language, especially in the beginning. It takes a while to know what normal looks like, and then in the absence of normal, reporting pathology and findings that are of concern, using language that I am concerned about this being somewhat suggestive of, however, the physical, you know what I mean? So leverage at first your physical exam and build your confidence into it and start doing this. Why do I say this? Because everybody does that. Physicians have to do that. They're much more cocky with wanting to describe pathology based on a bad image, and but they're not going to get nailed on it. We will. So we have to kind of have shinier halos. when we're integrating this into practice. Otherwise, that's the one I think maybe if I have a qualm, and it's not a big one, that somebody's going to think, oh, see, you shouldn't be using ultrasound. I You're going to get one or two. I think the genie's out of the bottle. It's ours for the taking. We just need to keep filling the room, as my colleague James Dauber says from Marshall University. Fill in the room until they realize that we're not going anywhere. We're not leaving. So opportunities, like I mentioned before, this is attractive for PT recruitment. People, you want to make sure that you can attract people and the brightest and the smartest. The research, oh my God, the research possibilities are crazy excellent. To follow the response to treatment, to whether it's dry needling under guidance, whether you're looking to see treatment response of various modalities to tissue mending. You can just imagine what can be done. Future reimbursement, I still think, again, you can charge a bunch for this, cash wise. I'm not going to be so crass as to name a number. I have a number in my mind that I'd be charging, but it would be upward of $200 per session, and I'd still wind up billing a therapeutic exercise code as well as an evaluation code. So, anyways, patient retention, amazing. For that, you get a patient who will buy in. A reputation for being a modern physical therapy practice. Patients love it, and improve diagnostics. So risk of inaction. This is my warning. Okay, if you don't want to, you say, well, it's too expensive. I can't put $3,700, and I don't want to send anybody to a course, or I don't want to send them to Sonos Skills for some evaluation. Well, fine. Then your competitors will learn it, and they will teach it, and they will wind up doing just fine. And you'll be behind the curve. I'm sorry, that's just the way it's going to be. I tried to convince everybody in our care hey, learn this, learn this, learn this. And they just wanted to know if they could refer it to somebody else. And I'm going like, okay, you forced me to be the guy that winds up teaching it. And here I am. I had no idea what a monster this would be in terms of how good this would be for my professional development and frankly for patient care. And I was already really good at this stuff in terms of treating a physical therapist, treating patients with manual therapies. So anyways, and like I said, I tell people and remind people, physical therapists who seek to practice to the top of their license will choose like-minded employment situations and like the vanguards such as Ben Keaton here. So easiest is bringing into practice barriers to ultrasound use. Buy your own device and practice to proficiency, integrated into your own evaluation. Just build 5 minutes, set 10 minutes just to see what you're looking at. What does that look like? What does this swelling look like? The institutional barriers are more difficult. Sometimes you're dealing with, and a lot of times, uninformed directors, uninformed PTs who, frankly, are just frightened of new technology, or, frankly, to be crass, fear that they've been left out and they don't want things to change. Radiology departments. It's like, oh my God. So you have to ask your uppers and your upper management, look, I'm just trying to use this stuff. It's part of my practice. I should be able to use this. Well, we have radiology. Where are you going to store your images? And blah, blah, blah. So the easiest independent practices have way more control over their fate when it comes to that. You really have to kind of negotiate with your institution and kind of say, and really build your alliances. It's doable. I've seen it. But you have to work at your negotiation skills. I think it's an opportunity to practice your negotiation strategies, but you might have to actually do some negotiation workshops because you gotta learn and be an advocate for this and be an advocate for the profession and your patients. So yeah, again, if you're dealing with institutional resistance, your rebuttal is ultrasound imaging is part of physical therapy practice. Don't go, well, we're starting to use it. No, it is part of your physical therapy practice. Be firm. Imaging storage with handhelds, HIPAA compliant. And like I said, you might need strategy to deal with radiologists and administrators. So my recommendation for departments who do not receive financial support for physical therapy for your own handhelds, at least allow physical therapists to invest in their own handhelds to use in practice. Give them space to do it. Have rounds. It's exciting stuff. It's so much fun. Encourage clinical implementation for PTs to develop skills. Don't prohibit physical therapists from using it in practice for evaluative purposes. You don't even have to say like, okay, let's be gentle about calling it a medical diagnosis. Okay, fine. Just, there are ways around that. So read your Practice Act. Legislative attempts are not required in the vast, and I mean 99.95, well, more like 96% of chances of circumstances. Eliciting a favorable ruling from a board requires careful, thoughtful inquiry. Consult us first. Choose your approach wisely, but talk to me. I'm available. So remember, there's no prohibition. Learn it, do it, practice to proficiency, just like everybody else does. A very learned radiologist and a role model to one of my colleagues who's a radiologist said, to get really good at this, you have to become a kid again and just enjoy anatomy. I got into physical therapy because I really love anatomy, and I've seen what good therapies can do for people in horrible chronic pain. And now with this tool, wow, sky's the limit. So work towards certification. It gives you a goal. A goal is a good thing. Even if it's just a POCUS certification, it's not nothing. It is a something for sure. But know that I want you to get the RMSK. And remember, I'm going to warn you again, beware a poorly phrased question and a clumsy state board inquiry. Please coordinate with APT Orthopedic SIG, which means me, for appropriate model phrasing and language. We have iterations. It's copy and paste, and just mold it to your Practice Act needs. Sorry, that's a lot of stuff. I hope I've at least overwhelmed you.
That was incredible. We had a very large portion stay on, throughout it. And I'm sure there's some questions brewing, although you were extremely comprehensive in answering those. For those who'd like, feel free to enter into the chat or the Q&A if you have a particular question that you'd like him to answer. But again, everyone that I had written in my head, Bruno, you answered as we went. It was, how does somebody get started? If you have inspired them to do so, you answered that well. The next was, how do we get paid? And I will echo too, I do think there are lots of opportunities on the cash side, not just to get a better reimbursement for your practice, but also to negotiate a better rate for yourself. An hour of your time as an in-network practitioner under the reimbursement of an insurance company tends to be a lot less well reimbursed than if you're doing a cash-based service. You might even double or more your potential earnings in the same amount of time.
Oh, absolutely.
And I've seen that in some of the organizations that are doing this. So great opportunity for anybody who's interested, and hopefully this gets out to the masses. So
yeah, I just think this is something that's going to it is elevating our profession. And this, I mean, is amazing when you can bring this diagnostic clarity to anyone, and you make the right call, and you talk with an orthopedist and say, hey, look, there's a loose body. This is the problem where the pain is. And also there's this impingement. Can you guys debride this? Is this something you want to, can you do this? We're investigating this possibility. You're offering him a procedure. It's just not just, we're not taking patients away. We're trying to channel the patients properly. And, there's a
and
weird.
It's amazing. It's amazing how the prognosis changes, how the plan changes when you have better data. Nothing ruins good assumptions like data. And I think this gives us an amazing opportunity to access a lot more data than we have in the past, and maybe would be surprised at how many assumptions we've made that may not have been substantiated the way we thought.
Brilliant point. Absolutely. That's why, you'd be surprised at it's like how much I've been surprised by the tissues and how much it's changed. How much it's changed practice.
It has.
It's really,
well, Bruno, I thank you for leading our profession in this direction, for so generously offering your time on a Tuesday evening. And to all those who are listening live, and for those who are watching the recording, please, please, please reach out. I'm happy to put you directly in contact with Dr. Steiner. Of course, he has shown his contact information as well. Use him as a resource, and let's move this forward for our profession. Thank you all. Have a great evening. And stay tuned for the next Residency Hot Topics. I'll be sending out information about that soon. Thank you again.
Thanks, Ben.